Hey folks, welcome back to the Brown Surgery Podcast. I'm your host, Dr. Kenneth Lynch. Today we have a special episode that touches on a topic that's receiving a lot of attention in the literature, but is not often talked about in general surgery or training programs. Imposter syndrome, or phenomenon as it was originally defined, is a feature that involves fear of being discovered and exposed as an imposter, or more simply, one who feels they do not belong in the role they occupy and does not deserve the success they achieve. To explore this concept in greater detail, we are fortunate enough to have a diverse panel of surgeons from Brown joining us today. With the help of Dr. Daryl Appleton, we will have an open conversation with Drs Christine Emmick, Dean Roye, Andrew Luhrs, and Elizabeth Tindal to explore this concept in greater detail.
Without further ado, Dr. Appleton, thank you for joining us today. As you all know, she's our speaker, and we're looking forward to her sessions that have become regular in the department and in our Grand Rounds curriculum. So I won't take any more time. We'll give the floor to Dr. Appleton.
Perfect. Thank you, Dr. Cotton. Good morning, everyone. Welcome to a very special Grand Rounds. We are having a panel discussion on imposter syndrome in general surgery. I'm Daryl Appleton. Joining me are Dr. Dean Roye, Dr. Christine Emmick, Dr. Liz Tindal, and Dr. Andrew Luhrs as they speak on their professional and personal experiences surrounding imposter syndrome. Now, imposter syndrome has been widely researched with studies showing that up to 80% of the general population has felt imposter syndrome at some point in their lives. And studies with general surgery trainees have echoed similar, if not more prevalent findings. We know that imposter syndrome is typically defined as feelings of self-doubt and personal incompetence that persist despite your education, experience, and accomplishments. And imposter syndrome keeps people from sharing their ideas, from applying for jobs, and seeking feedback for worry that their greatest fears of being inadequate will be confirmed. I've seen people with imposter syndrome that it completely cripples them and impacts their unmet potential. For the last 4 years working in the department, imposter syndrome is a qualitative topic that has come up time and time again, not just with residents, but with attendings as well. So the therapist in me decided that it was time that we talk about this. After reviewing dozens of questions that were sent in, we're going to structure this panel in 4 major subcategories. We're going to be talking about the panel's personal and professional impacts with imposter syndrome. We're going to be talking about strategies for helping self, strategies for helping others, and some global considerations for imposter syndrome in general surgery. But before we begin, I have to say a very deep thank you to all of you sitting in front of me today for allowing me to poke and prod in a vulnerable place in a very public setting. Truly, without you all here, this would not happen. Also, Dr. Chaffee, Dr. Miner, Dr. Lynch, thank you for lending me your staff, your residents, and your resources. It's not lost on me how important this conversation is. And even 5 years ago, I don't think we would be sitting here talking about this. So this is a very big thing for all of us here. And for those of you at home, Dr. Lynch will be manning the chat. So if there are any questions that pop up, he has my full permission to just shout them out, but we're definitely going to have time for questions at the end. Now, one of the most received questions that we got was about normalizing imposter syndrome. And they wanted to know, people at home wanted to know your experiences with imposter syndrome. So I'm going to open this up to all of you. And the question is, have you seen imposter syndrome, or how have you seen imposter syndrome manifest as an individual or in the context of surgical culture?
Sure, I'll start. So I think that certainly the era that I trained in, vulnerability as a surgeon was not something that was welcomed or really recognized. You were supposed to be the most competent person in the room. You were supposed to be, the conscience of the hospital. You were supposed to be all of these things, and most of them in the patient's best interest. But I think that didn't allow people to express vulnerability. And, I think that because of that, as time went on, we didn't recognize when we were, for lack of a better way of saying it, harming ourselves in terms of not recognizing when we needed to seek help, when we were dealing with tough times and you just kind of had to soldier on and move through it and so forth, and not really talk about the issues that were really affecting you. So as far as imposter syndrome, I think that when you get to the situation where you're uncertain as to what to do next, that imposter syndrome really makes you sort of close in rather than reach out. And I've been blessed to have many great mentors in my career, and I always felt like I had people I could turn to. I had people I could confide in. I had people who weren't going to judge me if I expressed doubt or inadequacies. And that support was really what helped me get through it.
How have you all felt about that? Is similar?
Yeah, I can echo that. I mean, I think I finished the same year as Dean, and I think early in your career, you're very vulnerable. You go from being this rock star as a senior resident, where you feel sort of invincible, and then all of a sudden you're in your own practice, and it's a whole different ball game. But I think I was lucky. I joined a practice that was very nurturing. They were always available to me, and I also noticed that not only were they helping me, they're helping each other in the same way. So I didn't feel sort of singled out as the newbie who needed more help. So that was reassuring. So I think you're right. I think we didn't recognize it back then. We didn't talk about it as much, but it was definitely a prevalent feeling. But I think that the important thing is now, especially to recognize where your mentors are. Don't be afraid to reach out, and I hope now it's a more open discussion for everybody.
Yeah, I mean, for me, I'd say my experiences with imposter syndrome were mostly in residency. I think I was on the tail. I was graduating as wellness was beginning in the residency. I said that tongue in cheek, obviously, but and I think it manifests in a couple of ways. One, just being found out that you don't know what you're supposed to know, right? So that can be like fear of talking on rounds, on particular services where you're expected to know, all the details of your patients. Certainly experienced that as a junior resident. And then, I think primarily for me was, when things aren't going well. I used to have a tough time in ICU, and you're thinking, am I cut out for this? And, for me, that kind of came to a crisis of conscience, if you want to call it that. It was just, am I going to continue to do this? And, for my third year of residency, I was seriously considering, aborting. And I had a single conversation with a senior resident who shared her experience with imposter syndrome and feeling like she wasn't cut out for it. She wrote me a very lovely letter, which is framed in my study, and that got me through. So I think when you talk about normalizing imposter syndrome, I think that's, to me, how it looks like, which is not necessarily self-care, but group care, and looking for the signs in others that you recognize in yourself, and taking that time to reach out and say, looks like you may be struggling, you had a rough go, or had a couple rough patient outcomes. Like, how are you feeling about it? And opening that door.
Yeah, I think a lot of it is one of the challenges that I have felt as a resident is it's really difficult to get a sense of where you are in terms of your operative skills, all of that sort of stuff. We have, our teams are set up so that you're on a spectrum of residents. You rarely are with someone of your own year. You're operating with either senior residents or attendings. So you always feel worse and not as good. And I think depending on how your brain processes those things, it can be really difficult. Like I remember as a second year resident getting an email saying I needed to do the attending that had done an FLS session, thought I needed more time doing intracorporeal knot tying practice. So I had a one-on-one session with a different attending. It happened to be during my consult rotation. So I was kind of tired, already feeling stretched thin. And the way that I took that was that I've been singled out as being bad at that. And I held on to that for a really, really long time, including into my third year when I started to think about wanting to do MIS. And part of where my brain was like, well, do I even have the right to want to do MIS? Like, who am I to say that I could do MIS? Because that one time, second year, and that must mean that I'm bad at this. And so I think it's one of those things that we also just need to be aware of kind of what that experience is like, and how some of those things that are even framed as educational can potentially be taken and processed and all of that.
And in my time working with surgeons, you all are perfectionists in your own rights. And I think sometimes that perfectionist piece and wanting to be the best, it's not a bad thing, but when it's framed in I have to be the best, or there is no room for error, sometimes we miss out on opportunities to learn, and all of a sudden it limits us. And I had two wonderful conversations. Well, I had wonderful conversations with all of you, but the women in the room, you guys both had really interesting things to say about being a female surgeon specifically, and some of your instances with imposter syndrome. Can you talk a little bit about that?
I mean, I think even training here 30 years ago, I think this has always been a very sort of female-friendly environment. I've never really had problems with discrimination or being treated differently. But, I think there's some different pressures. Again, I'll go back to when I first joined my practice. I was the only woman in a group of 7. And, I think I felt like an imposter in a lot of different levels, not sometimes, it's work. I think all of us being high achieving people, it's almost impossible to live up to our own expectations, which is in a way sort of healthy considering what we do. But I think it's just impossible to ever avoid feeling like I'm an imposter sometimes. But, then I would maybe have a great run at work where I was doing all these awesome cases and had great outcomes. And then I'd go home and my kids would be in bed and I hadn't seen them for 3 days. So I would feel like an imposter at home. Or one of my partners would tell me about how his wife ironed his underwear and my laundry is piling up in the laundry room for 3 weeks. So I would feel sort of as an imposter as a homemaker, so I think, and I know that's not specific for being a woman. I think the men are feeling these things too, but, kind of in the environment that I trained in early on, those were, just part of it. I was feeling like an imposter in several different areas of my life. And for me, I think my level of feeling this way, it's sort of was highest early on in my career when I didn't know how well I'd been trained, was trying to sort of create a reputation, and I felt like I was sort of under the microscope. So I felt really a lot of pressure to perform for those reasons. And then, as I realized going through it that, hey, I'm okay. I'm a pretty good surgeon here. But, every time you put yourself in a new uncomfortable situation, it would sort of, the levels of feeling that way would increase. Or anytime you had a run of either complications or not perfect outcomes, you'd feel little spikes of those feelings. So, I think, looking back on a longer career, I would say, there's always this baseline level of feeling this way, but then spikes depending on what's happening with your career choices or your outcomes.
Sure.
And I think from the resident perspective, there's a challenging line that you have to walk sometimes, where as part of our training and part of what we need to be able to do is run a room, say things strongly, and kind of own and command a situation. That's part of what we learn on trauma. It's part of what we need to be able to do if there's a code or something is going in the wrong direction. But you have to balance that with the fact that typically our interactions with, a lot of times it can be some of the nursing staff and everything. There's a whole other kind of sense of we have to be nice and we can't, and if you are forceful as a female resident, you run the risk of being kind of characterized as being a not nice word. So I think that's part of what you have to walk. And so it's kind of wearing these two different hats and it feels like you're having to do this extra thing to keep everybody happy and to maintain a good working environment with the people who are taking care of your patients. And I've seen that that's not necessarily, some of the male residents that I've worked with can say things in a forceful way, and it's not going to be taken as in the same way that if a female resident said it.
Sure, which I think is an interesting consideration for women specifically in this field. And Dr. Roye, you and I spoke about your challenges in your career as you move more into the administrative side, and how has that been different for you, moving from clinical to administrative?
Yeah, I think it's interesting to hear everybody's comments and how similar they are to the experiences that I had, which is part of the reason I think it's important to have these conversations and normalizing it to the extent that we are, because everybody goes through it, whether or not it's acknowledged or not. I would say that I, like you, finished and I felt some thoughts about, from being uber confident as a chief resident to the first appy that I saw as an attending, and I started questioning everything. And then we did the case and it's a nice normal appendix, appendicitis. But so it was one of those things where you question everything. As I went through my career as a surgeon, what I realized was I was well trained, and that kind of helped me get over those feelings of inadequacies or really questioning. When I went into administration, I would say I was genuinely not prepared. I was very prepared for managing people, managing behavioral problems and that sort of thing, because I did a lot of that as the division director. But the finance side of things talking to the chief financial officer at the hospital using their language, which was a foreign language to me. That gave me a lot of angst. So I ended up actually getting my MHA, my Master's of Healthcare Administration, to fill out the blanks in my preparation. So it was recognition of inadequacies, real or perceived, but then doing something actively to try and manage it. And it was really managing it was what made me feel more comfortable. And even, when you finish doing something and you're still a novice, relatively speaking, and you're speaking to masters at it, whether it's a surgeon and you're talking to somebody who's been doing it 20, 30 years, who knows everything like the back of their hand, you're still going to get those feelings of inadequacy. So it's taken me probably a good 3 to 5 years of having those conversations with chief financial officers and presidents of hospitals and so forth, to where I felt comfortable knowing what I knew and them feeling that they knew that I knew what I needed to know. So that was sort of the steps that I took along my path.
And I love that, which brings us into this next part of strategies for self when you're feeling these ways. And Dr. Luhrs, I know you said community was great and you have this thing framed in your office at home. Is it still nice to look at every now and again? Is that part of your strategy? If you're ever feeling like, okay, I need an extra boost?
Yeah, I mean, I think what I like thinking about this topic, what I've kind of realized is, if I asked everyone in this room, tell me like a great patient encounter you had, it might actually take a minute to think of. But if I ask you what was a negative, immediately, right? You've got 3 patients like on the top of your, on top of your mind. So we have this like kind of negative reinforcement bias where we're like continually thinking about the things that went wrong, but not necessarily remembering the things that went right. And so it is nice to have that reminder, which is the reason I framed it, right? It was, even though that was in the midst of several bad outcomes in an ICU, to be reminded that, hey, look back at all the things that you've done well. And so, I find myself doing that maybe even unconsciously when I have like a bad, I have a patient in the ICU currently. And so looking at all the other patients on the service who are doing great, like it kind of gives you energy for that person who needs you more. So I think, again, group care, but also self-care is important. Things.
What are some other strategies that you all use when you're feeling like I need a boost or I'm feeling not in a great headspace?
I think being flexible to be able to make some changes if you need to. So personally for me, I was working at Memorial Hospital, which was kind of going down the tubes financially and in a lot of different ways. And it was really, kind of a comfortable place for me to be. I'd been there for 20 years. I was a big fish in a little pond and knew everybody, but I could see where things were headed. So, I think it was just really a negative situation. And I think to be able to, see it coming and also to kind of be proactive and make some changes, even though it might have made me uncomfortable to make that switch at that point in life, it was, important. So I think for me, it's like sort of being kind of seeing what's coming and trying to be proactive and doing the things that I need to do to be happy and comfortable with my career. So like Dean getting his master's in public health, taking big steps to achieve, what you need to be happy.
Yeah, leaning into chaos a bit sometimes allows us to have some control over it. We did have a question about how do you manage constructive criticism or feedback without contributing to feelings of imposter syndrome? And as a resident, like getting lots of feedback, how has that been for you and how do you manage it?
So I am a big fan of take a moment. So like absorb it in that moment. Try not to, because I will, and immediately my responses will send me on a little bit of a spiral of just things that I'm not good enough or things that I'm not doing well, etc. So what I really have to do is I have to revisit that at a time when I just have a clearer head. And so I think a lot of this, in my opinion, I think I've tried to deal with this in a couple of ways. Some of it is preparation and dealing with it. If I've had something that happened, that I didn't like how it felt, like senior mock orals last year felt awful. And so it's just like part of how my brain processes it is like, okay, so then what am I going to do to think about it? So that's been like simmering in the back of my head since that time, fingers crossed for this year. But it's just like, it's kind of, I have to prepare for the situation so I can do better next time. I think you can't just like wallow in it was awful, and then not try to just really change it. And so I think the same way with that feedback, it's you have to be aware of what your brain is going to do. I think introspection is almost always the key to everything. So I know what my brain will do now, and I'm working on trying to kind of change the circuits a little bit. I have a sticker on my mirror at home that says, "Don't believe every thought you think." And it was sent to me randomly when I bought something else, and has just really grown on me. And I think that's part of it, is I have to be aware that I know where my brain is going to try to take this. That, I'm not good enough, I'm not smart enough, I'm lazy, any of these sorts of things. And I have to try to consciously make a decision to talk myself out of that and rewire how my brain works.
Yeah, it's interesting because feelings are information. We don't always think of feelings as information, and it allows us to address pain points rather than just assuming that this is now a fact. And those of you who meet with me know that I say this all the time: feelings are real and they're valid, but they are not facts, and we need to separate out the two of them.
Yeah. I think there are two parts to that question. One is, how do you give feedback constructively? And the other part is, how do you receive feedback constructively? And I think the receiving feedback constructively is understanding, particularly as a trainee, that you don't know everything. And I think all trainees know that they don't know everything. So it's not something that's difficult to understand. But realize that when you're here and you're being given feedback, it's an attempt by somebody to give you information to make you better. And because of that, assume the positive intent. And it's easy to feel like you're being attacked or being criticized or something like that when the person who's giving you the feedback really is probably genuinely just trying to give you feedback to make you better. So assuming the positive intent of the person who's giving you the feedback, and then as the person who's giving feedback, realize that the person you're giving the feedback to knows they made a mistake, or almost always knows they made a mistake or didn't do something as well as they could. So how you frame it, the tone that you use, and understanding that they may not be in a good mental space to receive that information at that moment in time is another thing. And as you start giving the feedback, if they're closing up and shrinking, probably it's not the time to give that feedback and step back and say, we'll talk about this some other time, maybe on round 0 on today or something like that, when they've had a little bit of time to process.
Yeah, and I think that's really great advice, and we'll definitely get into that more, because I think the strategies for helping others is being mindful of everything that Dr. Roye just said. There's also a question that I want you guys to answer on. What do you wish you would have known as a resident that you know now about imposter syndrome, or about the feelings that potentially come up about this? And this came up a few times in the questions.
I think that's easy for me. It's that I wasn't the only one experiencing it, that it was more or less ubiquitous at some point. Someone, people you're interacting with feel this way. And if they don't, it's kind of scary, right? Like, they should be feeling that. Yes. So I think, again, normalizing it is very healthy. But I think, again, I really like what Dean said early on, which is, I think imposter syndrome is maybe a little bit of a defense mechanism, because we don't want to I don't want to do the work to fix the problem, right? If I'm not having great outcomes, it means I need to do the work on my technique. Or if I don't know the answers on rounds, it means I need to do the reading. If I don't know how to speak finance lingo, I got to go get a master's degree, right? Like, it's easy to just say, well, I'm not good enough, so therefore I can't do this. But maybe it just means I need to do a little bit more work, and I'm not right not in the headspace to do it. Now, I think there's other areas of imposter syndrome where it's not that, but that's, for me, I think probably a big part of it is recognizing that there are points in my life where I'm not adequate for the task, and I need to do the work to get there.
Yeah, pain points are pain points, no matter how we look at it. And when you're in a place and a space, especially as surgeons, there's so many other competing things going on. It makes sense why just another thing to fix, or just another feeling to feel when you're thrown into a new situation, could be something that's overwhelming and then causes people to shut down even more so.
Yeah, Daryl, I re-listened to the lecture that you gave to the residents last year on this topic, and I was most impressed by how enthusiastically the discussion occurred afterwards. And one of the quotes, I don't know who said it, I couldn't recognize the voices, was like, 25 or 75% of residents admit to imposter syndrome, the other 25% are lying. Or if you don't have it, then, or you don't feel that way sometimes, then you have problems. So I think, like you said, recognition is important, to know everybody's feeling this way and to hopefully be more open to discussion with each other to help us through it.
Absolutely. Which brings us to, how do we help other people? What does that look like from a position of either power or understanding? How can we help those? How do we acknowledge that it's happening? How do we see the signs? And how do we help people through this?
I think as a young attending, one of the things I'm trying to learn to do well is give positive reinforcement when it's due. I think oftentimes, particularly in a surgical space, it's what could have gone better in this case, right? Even if it was a flawless gallbladder, we're talking about that, right? But to just say, you did a really great job with your tissue manipulation today. That was great, right? And if that, and then maybe let that sit for a minute or two, and then talk about what didn't go well or what we could have done better. So it's hard to do because we're wired, to what could we do better? How can we perform better? We're not necessarily wired to say this went great or you did well at this. So I think that's a piece of it. And so I think we can all do better in that, or in a certain way.
Yeah.
I think there's a lot of it. There's the perception at least to that from the resident perspective, that we get a lot of, and this is from our co-residents and from attendings, that we get a lot of the negative feedback. We don't hear the good things. And from being around as a med student and a resident, there are positive things being said. They're just not being said to the person's face. And so I try, if I hear a good thing said about somebody and they weren't there, I try to pass that along so that there's some of that like good feedback happening. Because I remember being an intern finishing a call shift at the Miriam, and I was just checking in, like the chief know that I was heading out because I'd finished everything, and Desiree said, "Good job," and I almost started crying. I was just like tired and like stressed and all that sort of stuff. And so I think some of that is like, we do need to say the good things, and I think there should be a focus on that as well. And I also think, like we talked a little bit about the constructive feedback needs to happen. And I think I've had situations with talking with attendings where it's somewhat of a heated or high stress situation, and I can tell they sometimes are having their initial reaction to it at me, and that maybe it's something that I did wrong, maybe it's not, maybe it's just a situation, but it's a very upsetting thing to absorb. And so I think also then having that ability to like tell that you're getting upset about something and being able to say like, here are the things that need to happen immediately. Give me a moment and like, let's talk about this. Because I know for me, and I'm trying to recognize this about myself when I'm talking with like medical students, junior residents, et cetera. I know that I'll have my initial reaction, and I know that oftentimes I'll have a more moderated reaction if I just give myself a moment to calm down, process, et cetera.
I think the other thing is don't be afraid to debrief after a difficult case with your colleagues, with your peers, with your mentors and so forth. I remember, Dr. Chaffee is one of my mentors. And when I was a mid-career, 10 years out or so in practice, I felt I had everything under control and master of my domain and so forth in the OR. And I got into a really difficult case and I called him and I'm like, I know where I need to go, but I don't know how to get there. And he looked around and he goes, I don't know how to get there either, but we're going to get there together. And, we did the case, we struggled through it. It was a really difficult case. And at the end, I remember sitting down in the recovery room after we talked to the family, and we just kind of batted ideas back and forth. What could we have done different? How would, and really sort of, going back to the beginning, should we have even been in the operating room? But just going through that with somebody that I really respected, that I thought was a master of his craft, was really comforting to me to know that, I felt like that point in time that I finally sort of arrived. I felt like I knew what I was doing, but now that, somebody that I really respected, I felt like I was at that level. And that really gave me that comfort to kind of go to the next step in my career. So
yeah, as a mentor, I think, he did a great thing for you and coming in and saying, hey, I don't know what to do either, but or not coming in and saying, hey, dude, obviously this is what you have to do. Yeah. So, I think that there are good and bad ways to be a mentor, but, to acknowledge that we all have limitations. I think, Liz, as an attending, sometimes things are so stressful for the attendings, unfortunately, the residents are sometimes first in the line of fire because you're right there. And so I think, one of the things other than trying to give positive feedback is also to realize that you can't lash out at people just because they're around because you're having stress. You have to kind of be mindful of how your reactions and your emotions are affecting people that are next door to you or trying to help and to take care of the patient.
Yeah, and all of you mentioned community and not feeling alone, and that's where imposter syndrome really is bred, is in captivity, in isolation. So how can we create better communities for attendings with residents, residents with residents? How do we really start to infuse this into our surgical culture?
So I'm glad you brought that up because that's one of the things that I've lamented over the last, 15, 20 years. I remember when I came here as the MIS fellow, and one of the things that struck me was the community. The residents at that time, they went out together. They would finish their work and they would go and find their colleague and say, what do you have next to do? Let's get it done so we can go out together. The nurses went out with the residents and et cetera. So it was this big community. I think as time, as the EMR, as, life has changed and evolved, we've gotten more insular. And I think we need to get back to a little bit more of that community, a little bit more of that outreach, a little bit more of that just, hanging together because we enjoy being with each other and we're going through the same difficult time. And not many people outside of what we're going through really genuinely understand what we're going through. So I do think that there's an opportunity for improvement in our community.
Yeah. Well, what would that look like?
I think it's a little different now. I think the residents specifically have, their own families and children when it wasn't the norm back then. But I agree with you 100%. Dean, my group in my practice at Memorial, we used to sit down twice a week and have breakfast together and just go over the list basically. And it was a real good opportunity just to, say, hey, what'd you think of the Patriots game last night? And just chat about stuff like that, but also, just to kind of discuss our patients and kind of feel each other out for what we do done differently. Do you think this guy needs to go to the OR? That kind of stuff. But I do miss that. And that was, I complained about it having to meet them for breakfast twice a week, but it was a real good, opportunity to get to know each other and to also, learn from each other. So I think little things like that can really go a long way.
When we talked in one of our lectures about dysfunctional teams, we talk about trust and this idea that we need to have trust in order to be vulnerable, in order to have difficult conversations, and even to fight in a productive way, like ways that we can make ourselves better and give that feedback. So what are some ideas around cultivating that trust within this department, within each other? Because I think that's a big thing that you guys are all hitting on beneath the surface here.
Well, I know for me, I've tried to, I feel like I personally have just been on a little bit of a journey over the course of residency. And so if I see somebody where I can kind of see some of what I've been through in them, I try in a gentle way to kind of check in and try to kind of see if my feeling is correct in terms of what they might be going through. I've tried to be really open about it was really hard. I've had kind of 2 parts of residency. I went through a big part of it and not wanting to be open at all about kind of my life and what I was going through and things like that. And then I've tried to be more open about it because I want all of us to be able to talk about it. We need to be aware of the things that are going on in each other's lives, and we need to, as much as people want to. And I think we need to, by doing that, we have a better sense of what people need from us, how to support each other. It allows people to openly set their own boundaries of what time is bedtime, what time are they trying to get home to, live that other part of their lives outside this hospital. And so I think we have to be open. And so, I've tried to pass along, I have a therapist. I've passed along the link that I use to find somebody. I have books that I've read that have been helpful. I Thought It Was Just Me by Brene Brown is wonderful. And so I have passed out that copy and things like that. And so I think some of it is just, we need to be as open as we'll feel comfortable being about kind of what we're going through, because we're all human. Part of this is we're all going through some element of this. And I think that by doing that, we can just support each other through it.
Right. I'm going to bring you.
Got in my car.
I don't know the answer to your question. How do we cultivate trust? But my gut response is that it probably starts at the top. So, attendings trusting chief residents who or trust mid-level residents who then trust interns. But how do you make that more like integrated part of the culture? I mean, I would say, at least in my practice, that there is a lot of trust that when, at least clinically, but then do I have trust with residents, emotionally or like interpersally? I don't know. I mean, I don't know. I have to think about that. That's a harder question, I think.
Journal about it.
Yeah.
Well, I think we have to find our people too.
Yeah.
Like when I was having my questions about going to MIS, like I asked Dr. Luhrs to sit down and talk about it. Like I felt like there was a certain kind of kindred spirit there in terms of, I felt like he would be honest with me and give me, the appropriate feedback and would help me find my way through and all of that in a very non-judgmental way. And so I think some of it is like, we just have to also trust our guts. We need to be open. We need to be willing to ask, Dr. Luhrs to meet for lunch or whoever it is. And so I think that's a big part of it. And I think just really quickly, going back to the benefit of the doubt, I think plays a big role too. I think we need to assume the best in each other. I think that, even when mistakes are made or things didn't happen quite the way that we would want them to, I think coming at it from a perspective of like, that person was lazy, that person, was negligent, that person is dumb, anything is probably not what was going on. There was probably a reason that it happened. And so I think coming at those situations of how we talk to the person who was on nights, who did XYZ for our patient, like having a conversation that doesn't start off as like, why did you do this? That feels aggressive, feels judgmental, feels like you were wrong, but more like, help me understand the situation, because I'm assuming you had data points that led you to make that decision. Right. And so it was either like, oh, okay, I see how you got there, or, okay, I would have also factored in these things and arrived at a different conclusion. So you can make it into an educational discussion. And I think those are some of the things, the interactions for us day to day amongst the residents that can help breed some of that trust as well.
I really like that. I feel like in medicine, there's a lot of the so-called moral repugnant other, like the us versus them. And we should not, at least in the Department of Surgery, should not be doing that to each other. I would say you shouldn't be doing it with it, but it's just the natural go-to, like you disagree with the way something happened. So like cardiology, they're a bunch of idiots, right? But they have the best interest of the patient in mind too. And ultimately we're all working together. So I think, trying to nip that in the bud, even if it's just like, oh, hey, we're not going to talk that way about Dr. Emmick, in my presence.
Right. And I think too, for those of you out there that we might have lost with all this touchy-feely stuff, it doesn't mean the hard work doesn't get done. It doesn't mean the hard conversations don't get done. It doesn't mean the feedback isn't given. It's sometimes not what we say, it's how we say it. And I think some strategies out there for people saying like, how do I check in with a resident? That's not part of who I am or what I was taught. Even just asking somebody, how are you? How are you really? Is something that can go a long way. Or like just a wellness check. What's going on? Good. We're ready to go. Okay, let's get our head in the game and let's get into the OR. Simple things like that really cultivate trust in teams and within each other. So trust me, you don't need to get into like, let's cry on each other's shoulders. Like, let's have an unpacking session. Doesn't need to look like that.
Yeah, I think that, leading into your mentors as well. We all, as residents at Birmingham, had assigned mentors, but it was my unassigned mentors who were really the people that I leaned into. People that, 20 years later, I still reached out to, communicated, and so forth. And there were people that, as I went through my experience as a resident, working with them, I connected with on a deeper level, and I felt more comfortable reaching out to them and discussing things that were probably things that made me a little bit more vulnerable, a little bit less confident, but being able to discuss it with them and then having frank conversations with them, knowing that they had my back almost regardless. So it was leaning into your mentors and identifying people that you connect with throughout the residency, and they don't necessarily have to be other attendants; it could be other residents.
I love that. You hear that, PGY once? Final question, and this is on the more global consideration side. How do you think culture and societal expectations contribute to imposter syndrome in surgery, and what can be done to impact and affect these broader issues?
I know one thing, we talked about gender a little bit before, but I've had plenty of times when I've gone to go meet patients for the first time, and I'll introduce myself as Dr. Tindal. If I'm meeting someone new, even if I'm wearing my white coat, etc., I try to use that initially and make sure they know I'm the doctor and all of that, just to clarify my role in it. But I've still had plenty of times where at the end of that interaction, the patient's wife walks in, it's like, oh, here, I'm just talking to one of the nurses type of a thing. And so, I think that is more of a kind of societal big picture thing that goes into it, but certainly plays a role in this feeling of, it's challenging then to like own being a surgeon and all of that when you're just trying to get to doctor nurse. And so, and then you have to handle that gracefully, and you can get mad. Like they mean well, but it's just, it's a litlittle bit of like a stab in the heart whenever it happens.
Yeah, I not infrequently will have entire visits in the office with patients who come to see Dr. Emmick, and then at the end of the visit, they'll be like, "And who's doing the surgery?" I'm like, that'd be me. So it happens not infrequently. I think clearly the face of surgery is changing. Like I said, I think we're in a unique situation where we train so many women here, and it's not like that across the country. But I think the face of surgery and the tenor of surgery is changing. I'm really hoping the medical student that I had in my office is listening to this, because he's talking about thinking about surgery, but he's really afraid of the sort of the malignant environment. I was like, I really don't think it's like that anymore. I think that, and I'm actually quite surprised to hear that you feel like it's still like that. So I was as nice as I humanly could be to this kid, helping that you can see that surgeons can be nice people. But yeah, I think it's hard to, obviously it's hard to make these global or changes in a field like that, but I think we're getting there for sure.
And I would say, as a Black man, training in the South and then going back to the South for a year as an attending, I had very similar experiences to what you're talking about. Have the conversation, and then Owen's a surgeon coming in, and but the reality of it is that you can't let that define you. You can't let that stop you. And when you feel like that stab to the heart, realize that it's no reflection on you, and you know it consciously, but subconsciously you do feel it. But I would say that being in the Northeast compared to the South, there's no comparison in terms of the acceptance of a diversity here that's just not in other places in the United States. So I certainly don't think about it when I'm here. I know when I go back south and go down to Miami and visit friends and family, I do think a little bit more about it, but I don't let that stop me.
Any final closing thoughts?
I will say there was one question, and we touched on it a little bit, is especially as a junior attending, maybe the expectation that you should know all the answers, or people expect you to have all the answers, but you don't have them. How do you deal with that? That was one of the questions that came through.
I'm, I guess, blessed in that I have a group of partners that work really well together. So it's, we're always in the office like, hey, like, can I just run something by you real quick? And I think just having a little bit of humility and like, I don't know the answer today, can you help me get there, is helpful. And to have a group of people around you that are willing to do that with you is super nice. So if you find yourself in the situation where that's not the case, then maybe reconsider your job choice. I
will also say we're blessed to be in an era of technology and information at your fingertips. When I've come across that, patient has a difficult, challenging problem or something like that, and I'm trying to sort through it, I'll tell patients, I'm not sure what's going on. I think it might be one of a couple things. Let me go look it up. I'll walk out and I'll look it up and I'll do my, that instant research and see if what I'm seeing matches. Picking up the phone and phoning a friend. Never be afraid to phone a friend. And that's one of the advantages of being in a bigger department, is that there are lots of people, lots of experience, and lots of specialists who may be able to see things from a different angle than you with your training. So, but information is out there and help is out there.
I love all that. I think some themes that I heard here were community is a big thing, allowing yourself to be vulnerable by asking for help, and really checking in how we respond to things, either to ourselves and what that looks like, how we speak back to ourselves, or as an attending or as a senior, how we speak to other people. It matters. You guys are all human beings that decided to be surgeons. And you guys aren't surgeons first. At the end of the day, I think we forget sometimes that we're just people, just trying to do our best.
I think Dr. Varney, you have a question?
I appreciate what everybody mentioned about trust in relationships and departments with our trainees, with our peers. And it never fails to amaze me how we fail in that. I'm going to say specifically trainees, but also to our peers. At least to me, from cultural anthropologist background, is we feel as imposters because we play roles. And that's how we quickly get in and out of new situations. We take on roles. And when we don't meet those expectations, that's when we have an imposter syndrome. But I don't think sometimes we take on bad roles. Like, I'm a senior surgeon, I can be a jerk. I'm the chief resident, I can make a snide comment to a junior, right? And then we learn bad roles. Guess what? Being a senior surgeon doesn't mean you can be a jerk and talk down, and somebody brings you bad news, go off on them. Being a chief doesn't mean you can say something demeaning to your intern or abuse other situations of power. And I think we need to be really cognizant of that, especially as we're talking about trust. I think more people blow it in these relationships from just not thinking and being kind to a peer and asking how someone's doing. When someone's down, not piling on. That's another thing. And I think in our roles with each other, I think that's something we really need to think about and actively prevent disrespectful behavior or demeaning language. In the affirmative, looking for acts of kindness to our peers, trainees, because it goes a long way. And that's what builds trust. The way I think of it, one snide comment, you might never ever get over it. So if you're having a bad day, think twice, take a deep breath, and measure your words, because I think we all, and this goes to interns to students at all levels where you're at, sometimes forget that because that's not one of the positive roles that we've learned in surgery. And that's something I think we have to be very thoughtful of and really try to improve on. So sorry, that wasn't a question, it was a statement, but that's what y'all got me thinking about from that. And I really appreciate everybody's time and statements, because it really does make a big difference to all of us as a faculty member to know I'm not alone when I have these moments, to a trainee to know I'm not alone when you have these moments, because we do. And as one of you said, the folks who say they don't probably aren't being straight with themselves. Thank you.
Thank you for being an honorary panel member. That was wonderful. And I think it's truly remarkable what we're doing here. And thank you all for being vulnerable again on a topic like this. This is remarkable because I don't think anyone else is having these conversations in surgery like this. So your department has done so many amazing things to move the needle forward into creating a really healthy environment in some of the hardest space for a profession to be in. And I think that support in that community and that trust is really underlying when we talk about healthy relationships of any kind, whether it's your marriage or your friendships or your working relationships. So it applies here as well. All right. Thank you all for being here in the metaverse and in real life. I'm truly blessed to be able to be a part of this conversation. Thank you all so much.
Appreciate it.
Thank you.
All right, this will conclude Grand Rounds. Thanks everyone for tuning in. So thanks again to all our panelists today for making this discussion incredibly engaging. If there are specific topics and/or specialties you'd like me to dive into in this podcast, my email's in the description, so just send me a quick note. Have a great week, and I'm looking forward to having you back with us in the next episode of the Brown Surgery Podcast.